Hello, I'm Dr. Frank Arena, Cardiac Vascular and Vein Center, Covington, Louisiana, here to talk about design attributes and limitations of the Supera Stent. I'd like to thank Dr. Walker and everybody from NCVH for inviting me today. I have no disclosures relevant to this presentation. Everybody's seen this slide before. The SFA stents function in a very complex environment in the infra-inguinal arteries. They extend and contract, they twist, compress, and flex. But I don't think people really appreciate how much of a hostile environment it is for these stents. As you can see on the left, when the leg is straight, there's 11 centimeters between the edge of the stent placed and the ostium. And when the leg is shortened, you can see that distance compresses to 9.5 centimeters. This is pretty consistent across superficial femoral arteries, where there's about 10 to 15% compression throughout the length of the SFA and popliteal. Now, where this matters is that if a stent does not have good longitudinal compliance, then that shortening is forced to occur over a much smaller space, which can often cause kinking and various compression anomalies of the adjacent artery. It can also put extreme forces on the stent, which can lead to a fracture. We often see nitinol stents fracture in areas adjacent to overlap, where the forces of the bending and motion occur on the area of the stent that is not extra rigid in the as would be in the overlap in the more nominal portions, and often that is more than the stent can tolerate and creates significant compression, as is the picture on the right. And this study by Dr. Scheiner and many others have shown that stent fracture is a leading implication in decreased patency, and sometimes substantially so. I think what a lot of people don't appreciate is the effect of the edge of the stent on the artery that's moving, and how much trauma can occur at the edge of the stent, as the picture on the right. Often, if there's significant amounts of stent placed, which is forced to occur in TAS C and D lesions fairly commonly, you'll see kinking of the stents in various places, as well as, again, what we discussed, the anomalies of the bending artery up against the edge of the stent. And in this picture, you can see this is the same leg, one straight, one bent. Straight on the left looks fairly good, nice artery, widely patent. But on the right side, you can see when the leg is bent, it creates an accordion-like effect on the residual artery, as the entire amount of shortening is forced to occur over a fairly small distance. Now, this matters because when you do intravascular ultrasound of these stents, and I would really recommend that people do that so they can learn how their stents look, and learn how the rest of the artery looks, especially if you have the opportunity to do it with the leg bent. There aren't many trials of intravascular ultrasound in SFA stents, but if you do these ultrasounds, a common experience and anecdote would suggest that the nitinol stents often leave areas of compression and residual stenosis due to external compression. There is one trial of interwoven nitinol, which is what the Supera stent is, that showed excellent stent expansion ratios of 96 and 88% for the 5.5 and 6.5%, with very few areas of severe compression of more than 50%. This particular ultrasound is of 42 centimeters of interwoven nitinol at 5.5 centimeters with an 8x20 EV3 stent at the very ostium. And you can see how there's, even though it was well deployed at 16 atmospheres, there was significant compression from external forces on that stent. Which again brings us to the Supera stent. This is a new type of design for nitinol stents, and has several theoretic important advantages. It basically looks like a slinky. It has a very good extension and compression resistance. or compliance, I should say, and also durability and compression resistance, which we'll show in the next slide. We can see that this stent has 4 times compression, 4 times greater compression resistance than standard nitinol stents, which is substantial. And again, going back to our previous video, we can definitely see the difference in roundness in a very hostile, heavily calcified artery between the nitinol stent on the left and the Supera stent on the right. So why does this matter? There are, again, not many studies that were done with IVUS, but there are 2 that I was able to find that are roughly comparable. And what we saw in interwoven nitinol that had very good average and maximum stent areas of 19 and almost 25 square millimeters, which was similar to the smart stent, but the minimum area was generally a little better with the interwoven nitinol at 15 and 19 square millimeters, which was better than the 13 and 14 of the smart stent. So why is this important? Because basically in the smart stent trial, 15.5 square millimeters was the cutoff for increased restenosis, and that's more common among the traditional stents in that study. As we saw, stent expansion ratio, which would be expected, was much better with interwoven nitinol in the Supera stent than it was with the smart, and also regional symmetry index, which is basically a measure of roundness, was again much better with the interwoven nitinol than the traditional nitinol stent. So this brings us to the SUPERB trial. It was a U.S. prospective multi-centered randomized or non-randomized trial, excuse me. It was the basis for the FDA approval for this stent. And you have to remember, as traditional nitinol stents, they were originally made for common bile duct applications, and I've never seen a 15-centimeter common bile duct, but they weren't exactly created for the SFA environment. And this was again the basis for the FDA approval. It had independent duplex ultrasound and core laboratories, and basically it checked on vessel patency at 12 months, as well as which was defined as freedom from restenosis based on peak systolic velocities and a TLR. It did meet its primary patency rates of 86.3% at 12 months, Kaplan-Meier, and 90.5% with nominal deployment, which is an important point that we'll talk about a little bit later. Interestingly, which is also something unusual for SFA stent trials, there was minimal change in the reintervention rate between 12 and 36 months, very little drop off. And there was also high freedom from restenosis independent of length, short, medium, and long lesions with very few fractures, only 1 at 36 months. As we see in this slide, very good Kaplan-Meier patency at 12 months and very good Viva patency at 12 months with, again, substantial freedom from restenosis and TLR over 3 years. This slide again shows that there was severe calcium at 45% of these lesions, which is a relatively real-world population. Now, we talked about the nominal deployments earlier. So nominal means basically if you deploy the stent within 10% of its true length, of its normal length. As you can see, if you did place the stent well as nominal deployment, the Supera stent just performed superbly. If it was less than optimal deployment, there was some fall off in the performance of the stent, as you can see. So again, talking about calcium, there were many heavily calcified vessels in this trial, 45% or 118 patients, and those patients, the stent performed very, very well over time, 95 to 88% TLR freedom at 36 months. And also in long lesions, whether it was 4 centimeters, 7, or 13 centimeters, the stent performed pretty much the same for all three groups, which is, again, very unusual for SFA stent trials. So when we talk about nominal deployment, this is not the kind of stent that you can just put in and then post-dilate. You'll get a very poor result if you do that. You really need to pre-dilate very aggressively. Often the company will tell you to use a millimeter larger balloon and go to nominal size, and then have a long inflation, maybe a minute or so. Some people, including myself, often will use the same size balloon at high atmospheres, 15 or above, again for a fairly long inflation. And then when you place the stent, you want to do it on high mag. You want to do it relatively slowly. I often keep my left hand on the device, keeping positive pressure as I use my right hand to deploy it, making sure that the cells stack appropriately. And I'll show on this slide and the next slide, you can see the difference between a nominal deployment, where you'll have these little black dots along the edge, and the cell geometry will be about 2 to 1 in size, versus a stacked or elongated, as you can see on the right side of the page. Again, some more pictures of nominal, compressed, or elongated stents. You really want to avoid the elongated stents, which is why pre-ballooning is just so important. Now, as we saw again in the study, when the stent was placed at the nominal and placed well, it did fantastically, 97 down to 94% at 36 months. If there was compression, there was some fall off in performance, but it was still pretty good, 91 down to 87. But if it was elongated, especially if it was severely elongated, performance really fell off fairly dramatically, and you really want to try to avoid that if you possibly can. So thank you very much. Appreciate everybody today taking the time. I hope this has piqued your interest in this particular stent and its advantages in the SFA.